Welcome to our podcast, Psychiatric Services from Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with podcast editor and my co-host, Josh Berezin. Hi, Josh.
Hi, Lisa.
So today we are going to talk about an article authored by Mark Savill, Teresa Nguyen, Ruth Shim, and Rachel Lowy that describes a study on online psychosis screening. And I think you'll find it really interesting.
Today we have Dr. Mark Savill, who's an assistant professor in the Department of Psychiatry and Behavioral Sciences at the University of California, Davis, here to talk about his article, Online Psychosis Screening, Characterizing an Underexamined Population to Improve Access and Equity. So Dr. Savill, thanks so much for joining us on this daylight savings time morning from the West Coast. We really appreciate it.
Absolutely. Very early, but happy to be here.
You know, per usual, I think we'll start out with a question just about a little bit about your background, how you came to this kind of corner of research in the context of your general interest and career course.
Sure. So as your listeners have probably already determined, I'm British. So I can start there. So I moved over to the US about 6-7 years ago now. So I did my Ph.D. in England with somebody called Professor Stefan Prieber, and it was at the WHO Collaborating Center for Mental Health Services Research. So it had a very social psychiatry, social services focus. And when I was there, my PhD was around negative symptoms of schizophrenia. And at the same time, I was running a clinical trial around trying to address negative symptoms with something called body psychotherapy, which is probably a whole conversation by itself. So I moved over about 5 or 6 years ago. I have a wife who's from California, so I moved with her. And I think when I first came, I wasn't entirely sure where I fit. So I think very social psychiatry, services research, and my perception, at least of the US model, was much more basic science, neuroscience when thinking about severe mental illness. So not really sure kind of where I fit and where I'd be useful. So I was very fortunate, sort of speaking through a few contacts I had in the UK, to be introduced to somebody called Dr. Rachel Lowy. And she is somebody who produced the PQB. So this is the tool that we're using in the paper that we're talking about. And it was really from there, sort of, as things can often happen in research, it kind of snowballed. So the more we were talking about this, sort of realizing how it linked with a lot of our collaborators, primarily Dr. Tara Needham, who's someone I work with now at UC Davis, got introduced to her. And we just kind of snowballed from there. So a lot of thinking about improving pathways and access to care, and how screening in particular can be one method in which to try and reduce duration of untreated psychosis and then try and improve and refine these pathways into sort of providing services for people in need.
So you referred to the PQB. Could you just say what that is?
Sure. So the PQB is the Prodromal Questionnaire Brief. So there's a number of different versions of it. This is the 21 item version, which is sort of the more recent version. It's a bit more condensed, so it's more feasible to use in sort of clinical and community settings.
So we'll dive in more into the survey and how you used it. But before we do, just to set a little bit of context, you mentioned duration of untreated psychosis. And I think that's an important piece of context to set up the paper and the study and why you're actually doing this. So could you talk a little bit about that? Like why is that a construct and why is that important to address?
Sure. So DUP, or duration of untreated psychosis, is a pretty simple concept in itself. It's just essentially when psychosis starts, and then when treatment starts is that duration of time between those two time points. And it's important because for a couple of decades now, I think sort of the papers from Jenna Perkins and Matt Birchwood and others sort of in the early 2000s really showed how much of an impact that the length of illness prior to treatment can have on treatment response and functional outcomes. So sort of things that are key when we're thinking about treating people with psychosis. And I think it got even greater attention as a consequence of the RAISE study by Lisa Dixon here, John Kane and others, where the impact of the intervention, sort of impact of coordinated specialty care, was mediated a lot by the length of the illness they had prior to coming in. So it's sort of, we've thought about it for a long time, particularly in the last few years. It's been a real focus about thinking about how to try and reduce that DUP, to really try and improve the effectiveness of the care that we deliver and try and improve functional outcomes for people with psychosis.
Lisa, do you have any thing to add about duration of untreated psychosis?
No, I don't. I appreciate Dr. Savill's attributing some importance to the RAISE projects. I think Dr. Kane's and the RAISE UTP group really had a very striking finding of the benefits of their intervention, Navigate, only really being apparent for people with a shorter duration of untreated psychosis. The only thing I would just clarify is, to me, the beginning of treatment is a little bit dicey. Like, what does that mean?
Absolutely.
So I know.
Right. And that was kind of, I think, where I was going to go when I was saying on the surface seems very simple.
Right.
So, and that's something we've been grappling with an awful lot. Like, what does the start of treatment actually mean? Is it the first time you receive an antipsychotic? Is it full integration into a coordinated specialty care service? Or is it anything in between? So I think that is muddied, and you look at the literature, a lot of different ways it's been interpreted as well. So sometimes it's very difficult to compare and contrast across studies just because we define this so differently. And then also, as someone that's done a lot of clinical assessments, particularly people with clinical high risk, in addition to first episode psychosis, it can be very hard to diagnose someone just at the point of diagnosis. To be able to determine exactly when someone transitioned from this period of sort of clinical high risk or prodromal symptoms, or whatever term you want to use, to full psychosis can be hugely difficult. And it can be complicated by having various reports that may conflict with each other. It may be someone actively taking substances or trauma, or there may be a whole multitude of factors that can really mean pinpointing that point when we think of it as a start of psychosis can be hugely difficult. So again, a very easy term on the surface, but I think it's something that we as a field need to be much more systematic about understanding and sort of defining what this period might mean, particularly given it's something that is part of our inclusion criteria for a lot of these services, but also is something that seems to have a huge impact on treatment response and outcomes. So I think that's something for the field that we're grappling with and thinking about quite a lot.
At its most basic, somebody develops psychotic symptoms, and then there's some delay until they seek services or they're in treatment.
Right.
And we have some evidence that the shorter that period is, the better the outcomes. And so there's a focus on, like, well, how do we decrease that period of time from symptoms to treatment? How is the internet potentially like a solution here, which is the other kind of big piece of context for the paper?
When we think about duration of untreated psychosis, there's a push to kind of think about it. It really is kind of two discrete pieces. So we have the demand side, DUP, sorry about that, and then the supply side DUP. And that is the amount of time where someone may develop a psychotic disorder, and it's the length of time it takes before they decide they actually need to seek help. And they may go and see their GP, or they may start engaging with services to sort of initiate that process. And then at that point, it's then that length of time from seeing their GP or whoever their sort of provider is to the point where they may actually get the specialty care that they need. So it's these two sort of very discrete pieces. The interventions that we have are typically different. So to improve or reduce the demand side, it could be things like advertising campaigns or destigmatization kind of efforts to really kind of reduce that time, or for people to be aware that they may need to seek help. And then there's the supply side, where it's outreach and education of GPs or community mental health centers, or screening in their settings to reduce that time too. So it's different kind of interventions to think about how we reduce this. And I think one of the many reasons the internet screening may be incredibly helpful in this area is it's really sort of tackling both at the same time. The internet's one of the first ports of calls where people think they may have a health concern. So in any field, so I have a bad cold, I have, I don't know, something on my foot or whatever, like I'll check the internet to see what this is. Oh, okay, I need to go and see the GP, this is serious. Exactly the same in mental health too. So that's improving our demand side. So hopefully reducing that bit. The second bit is once we're screening, once we're exhibiting positive symptoms and a distress associated with those symptoms, it's hopefully linking someone directly to somebody that knows exactly how to assess what this means and provide the right level of care. So you're not going from your GP to your non-specific kind of community mental health center. And then from there, oh, okay, this isn't just depression, this may be psychosis, and we need to have someone with more specialist thoughts about how to help this person. So it's kind of cutting out a lot of the middlemen, but also kind of having a much earlier port of call for the person perhaps in need to be able to understand what's going on.
It's funny, I actually this morning looked up there's something on my foot. And I didn't actually get
I chose that one.
Yeah, I didn't actually get like that much useful information, or it took me a little while. Like, do you have a sense of how people who might be experiencing first episode psychosis or prodromal symptoms, like, what do you have a sense of what they're searching for? What are they putting in, and what are they getting back? Because I could imagine it could be anything from like a YouTube video that's like a song lyric to something that's totally unrelated to the exact right resource?
This bit's a little bit outside of my expertise. Like, I think that could be a whole conversation in itself. There's a number of people at Mental Health America, I think, who could give you a fascinating insight around that. What I do know is if you type in, am I mentally ill? Am I experiencing psychosis? The first thing that comes up is Mental Health America. And I think that's a huge part of why they're getting the numbers and the traffic that they are, that we'll probably be talking about a little bit later. So I think how people develop sort of the search algorithms, how they maximize this is a huge part of this being effective. And I think to the credit of Mental Health America, they've been very effective in doing so.
So I think that's a good segue into some of the details of the paper, because you are looking at a screening that's on this particular website, Mental Health America. So maybe you could talk, you mentioned it earlier, but maybe talk a little bit more about the screen and kind of how that works within Mental Health America's website, and then maybe just sketch the broad outlines of what you were inquiring about in this particular study.
Mental Health America is an organization that provides kind of resources and information for people with varying experiences of mental health or behavioral health distress. And there's a number of resources on there. There's a lot of things around sort of basic psych ed. There are sort of a lot of contact lists about who to contact in your region if you are having these experiences. And then there's a particular section which is really focused on screening, and the idea being to help people understand the experiences that they may be having. And then from there, sort of empowering people to think about what they may want next. The website has, I think, about 12 to 14 different screeners. So it looks at things like depression, anxiety, PTSD symptoms, and it's using kind of very extensively validated tools for each area. So the depression one would be PHQ-9, anxiety would be the GAD-7, and then the psychosis screen, which is sort of the area that this paper is very much the focus on, is the PQB. It's a extensively validated tool that's been used in clinical and community setting for a while now, that's linked to that. And then if someone is scoring above sort of a clinical threshold, the idea then is to signpost people to either receive more information, or if they're ready to reach out to somebody to think about treatment options or what their next steps might be.
I have a question about that, because I want to make sure our listeners understand the difference between identifying people with psychosis, as we would define it, versus someone with near psychosis, but not quite psychosis as far as we can tell, like the attenuated or I hate all these words, so I'm using them with sort of great care, but prodromal. Where does the PQB fit in that kind of space?
The PQB is calibrated very much to identify people that may be experiencing psychotic-like symptoms across the spectrum. So it's originally really designed for people to identify people, to pick up the more attenuated symptoms, as you described, Lisa. So someone that may be sort of seeing very vague shapes in the corner of their eye, but it's something that they can dismiss, not something that's there with sort of huge debilitating or have complete conviction around what they may or may not be seeing. So it's a much lower threshold from what we would typically think about when someone is at psychosis. And then I think another thing that's super important to think about when we think about these screening tools is that it's not a diagnostic tool. So not only is it not calibrated for someone at sort of full threshold of psychosis, if you're scoring high on this, it doesn't necessarily mean that you have clinical high risk either. And the idea is very much to identify people that are experiencing these kind of psychotic-like symptoms, may have distress associated with them, and so as a result would benefit from a more extensive interview or support with someone. Because again, part of the challenge is it can be very non-specific. It may be attributable to substances. It may be traumatic re-experiencing. It could be a whole host of other things that aren't psychosis. So I think part of when we're using these kind of tools is to be very clear, and particularly to the people that are filling these in, that it's just indicative of perhaps needing a higher level of support or understanding or assessment, not that, oh, okay, you're diagnosed with this thing now.
Okay, so we have a population of people who are experiencing some maybe prodromal psychotic symptoms. We have this idea that they're using the internet and they're going online. A lot of them are being funneled to this particular website, Mental Health America, and taking this screen. So what did you all investigate in terms of the study?
Sort of from previous work, we know that searching for health information is a very common activity for people to do, and particularly young people when they may be experiencing things and they're not too sure what it is. There's other work that shows sort of outreach and engagement and advertising is very successful at pulling people in. But the issue that we have at the moment is how that sort of translates then to people actually seeking care. And what we really wanted to do was just to understand the population who is completing these kind of things much better, to then really know and think about and understand how this can then be part of a bigger pathway to actually bringing people into care, into services, or addressing needs. I was fortunate to speak to sort of various colleagues at Mental Health America a few years ago. I met her at a conference, and it was, oh, you work with Rachel Levy, who's the one who produced this. We've started this thing and it's just exploded. We're getting so many numbers, we almost have no idea what to do with all this data. And that's really where the conversation started. And so very early, I was aware of just how remarkable the outreach and the engagement that we're having in this kind of tool. And I think that's the part where we really got excited about thinking about how this really could be a way to transform how we bring people into care. But there's a huge amount of question marks around it. And I think before we can even really think about that as what this may look like in the pathway, is a lot of work to understand, well, what are the type of experiences that people are having? Is it lots of people that are just genuinely curious about symptoms, or is it people that have very high distress and very high need? We don't know who the type of people are that are filling these things in. Early psychosis services, particularly across the US, are very focused on transitional age youth and younger populations. So does it kind of line up with the people that we're actually trying to target to treat with these kind of services? And then just understanding what they want. So this is typically when people are filling in sort of internet surveys and things at the very earliest stages of help seeking. So they may be very ambivalent about wanting to seek care or knowing what that even might mean. So understanding what they actually want is a huge part to be able to address those needs, and also perhaps try and bridge that gap between having enough concern about what you're having to go on a website specifically for this versus actually committing to engaging in treatment, making a phone call, turning up to an assessment. Is that huge gap in the middle, I think. And part of what this work was about is really sort of understanding the population in youth in the next stage, thinking about, okay, so how can we bridge that gap? How can we support people to sort of make that pathway to care? Or if they're not ready to go into care yet, what they may want instead, which is another, I think, important thing to think about. Is, I think, as researchers and care providers, we have this kind of very fixed idea of these kind of institutions that people come in and that's where they receive their care. But when you talk to people, it's a much more graded kind of pathway to receiving that. And is there something that we could be providing before that? Is it psych ed? Is it sort of helping people understand their symptoms a bit more? Is it some very basic coping skills just to kind of take the edge off when they're in kind of when they're very much in the eye of the storm, they're not ready for care yet? Or is it about motivation enhancement to kind of support people to make that step towards care earlier? So that's, I think, what really motivated me about this population in particular, and thinking about how we can perhaps address DUP and also address an unmet need. I think that's another thing as well, is a lot of these people are experiencing quite substantial distress. And outside of the idea of reducing DUP, which is a huge focus for us, I think a big part is there's a lot of people, a lot of young kids out there that have very real distress associated with these symptoms, but aren't receiving support for them yet. And I think that's a huge part as well to think about, in addition to just reducing the length before we can get them into care.
One thing I really like about that explanation is it seems at first glance that getting somebody into care is like it's A to B, right? Like somebody needs to get evaluated, so they're at point A, and then point B is the evaluation point. But that's really like or something like that, right? There's all these different steps between those and different kind of pathways that people can take. And I just appreciate kind of understanding a little bit more about how nuanced some of this is, and getting somebody into care is really like a complex process that we need to understand a lot better if we're going to gear services towards people.
Absolutely. And I think that's very much what we're thinking about for kind of the study that follows this study. So we've been working sort of fairly extensively with some colleagues at Strong 365, with Michael Birnbaum and others, that have really thought about trying to bridge this gap. So it's things like having a 24-hour phone line so we can speak to people immediately, because that immediate contact can be so critical. It's thinking about the role that peers might have and being able to kind of demystify and destigmatize some of this and it not feel so kind of medicalized. So there's a number of things we're thinking about within the context of a trial to try and sort of support people to go from this kind of contemplative sort of level where they're aware something's going on and they're thinking about what they might need, to a kind of more of an action state where, okay, I am going into a clinic, I am speaking to somebody, and I do want to get this fixed because it's something that's impairing and distressing, and it is something that I want to rectify myself.
So what did you learn?
I think we learned an awful lot, actually. So the couple of real big takeaways for me is just how much the extent of the need and the distress of the population was evident. So the PQB scores that people were reporting were, I think, hugely surprising to everyone on the program. Over 80% of them are scoring 20 or higher. And that means that they're experiencing multiple psychotic-like symptoms, and they're reporting pretty pronounced distress associated with this. So what we're finding is it's not just a bunch of people that are curious and interested about what this might be. It's a lot of people that are self-reporting really quite substantial distress or impairment that's associated with these types of symptoms. So it's very much meeting or finding people that are exhibiting a lot of
suffering.
That's
it's almost like they're suffering. Yeah.
Yes, I think that's a much more human way of saying it. So thank you. I think that's a huge part. Then the second part is just how varied what people actually want as a consequence of hearing this. So again, 80% of people are saying their distress is at a level where perhaps a follow-up assessment is necessary, but the majority of them wanted more information first. They wanted to peruse the website more to get more information about what this might mean or what these symptoms are, or they may want to speak to a family member or a friend. The first port of call wasn't thinking about treatment. I think it was only about 17% of people actually thought, okay, this is something you're telling me is something I need support and help with, so perhaps I should speak to someone or speak to a specialist about this. That wasn't what people wanted. And I think, again, that really highlights this idea of thinking about what happens between A to L, as you kind of nicely put it. I think that was a really pronounced finding as well, and shows that it's like just finding these people is really only half the story. It's the support and the thinking about what people's needs might be to kind of get you from A to L is really kind of a huge part of this conversation. And then I think another thing is the variation that we saw across sociodemographics as well, I think is important. One of the other ones that certainly surprised me was the fact that African Americans were much more receptive towards the idea of receiving treatment than sort of other racial and ethnic groups. And I have to admit, sort of from the work I do, you kind of perpetually hear this idea about greater stigma towards mental health services and treatment in particular communities, and that being a focus that we need to address. And I think it was very pronounced that actually this data suggested the opposite, where people from African-American communities were actually much more receptive to the idea of receiving services and actively said they want to receive treatment. So I think that kind of flies in the face of that a little bit. And I think it was quite thought-provoking because we do see persistent disparities in community behavioral health care. Like we see particularly African Americans are underrepresented in these communities. And there is this perception where, so it's destigmatization efforts, and it's sort of making the community think differently about behavioral health is kind of what needs to happen. And that's kind of putting the onus on the communities and the individuals themselves. And I think this kind of data, and it links a lot with what the work that Ruth Shim's done and others, which I think is really helpful for us to think about and interpret what this means, is actually just shifted much more back on the clinical services and the system of care that we have ourselves. And it's much more sort of shine the spotlight more on what we do as services researchers.
I just wanted to point out also that Ruth Shim is a co-author on the paper.
Yes, thank you. Yes, and again, it's thinking about, okay, well, if it's not about attitudes towards care, then what's causing these disparities? It rather than sort of destigmatization efforts, is it much more thinking about access? Is it where these programs are? Are they in the communities where the need is? We're thinking about assumptions that providers might have where the idea is that people may be more resistant to treatment, but they actually aren't, at least on a population level, what we're seeing. Is it insurance barriers, which is a huge problem when we think about kind of behavioral health care across this country? It may be the importance of language services, whether we can actually appropriately engage with various sort of people within our community. So I think it's a lot of things to think about that shifts the emphasis much more on us as services researchers and of service providers generally, and much less about, this community just needs to change about what their thoughts are about treatment, and then things will be fine and rosy. So I think that's quite a thought-provoking thing as a service researcher, but I think that's an important thing to keep in mind.
It is very thought-provoking, and it also, you look around and sometimes you wonder if some of the things that get implemented are actually going to solve the problem that they're targeting. And so This research seems very important to be like, well, let's make sure that we actually understand what the issues are.
I wanted to ask you to give some numbers because I just was blown away by the number of respondents, that people who filled this out. I know you mentioned it, but I'm looking at your abstract, 120,937 people.
Yeah, it's remarkable. So sort of speaking to Teresa recently, and I'm sure the way this goes, the numbers go up incredibly between every time I talk to her. Last time I spoke to her, they had over 7 million screens across their 12 different screeners. And the numbers that we have in this paper are from 2017. They've gone up recently again, and particularly during the COVID pandemic, they found an explosion in these being filled in. I think it's, at the moment, it's settling in at around 250,000 a year. So it's an enormous number. And I think that really kind of highlights two things. One is the success that they've had as an organization at being able to bring people in and sort of try and create traffic to their website. But then the second thing, which I think is perhaps even more important, is just the huge need that's there. I mean, for 7 million people to be using this one website to try and understand what mental health or behavioral health symptoms they're experiencing is just showing us how the magnitude of what the need and the experiences that we're seeing in our communities, and the onus on us really thinking about, from identification, how we can start thinking about addressing some of this need.
It seems like this opens up so many different potential lines of inquiry. Do you have projects that are in the works to start answering some of these questions? Absolutely.
I mean, we're researchers. That's what we do. We find questions, then we create more questions, and we try and answer those questions with more questions. So yes, I think, and hopefully it's sort of clear in the paper, there are a number of limitations to this. And I think a big part of the work is really thinking about and interpreting what this data actually means. So a huge thing for me is, again, like, it was quite mind-blowing, just the level of need and the severity of symptoms that were being recorded. They were so high and the prevalence was so high. Part of me is kind of very cautious about interpreting what that actually means. And I think part of that is thinking about what it is to fill in one of these things and how versus how it's historically done. So in the past, what typically happens is someone experiences these types of symptoms. It's frequent and prolonged enough. Okay, I'm going to go and see someone. And then it's at your school counseling service, maybe a few days later, or at your GP clinic a week or so later, where you're filling this thing in a sort of sanitized setting. On the online, you can be filling this in right in the middle of the eye of the storm. So I'm having all these experiences. I have no idea what they are. Okay, I'm going to go online and check. And I think the immediacy of filling these things in versus having a few days to reappraise what these experiences might be, or to kind of, particularly around psychosis, because it's around the extent to which you question the reality of things a little bit, and how you're experiencing it in the moment is likely to be very different to how you reappraise something a week later. So part of my concern is that because this is so immediate, it might be a more accurate reflection of what their experiences are at the time, which I think is important and interesting. But our tools are very much calibrated to where we think about when someone fills this in a week later. So what may be a 20 in the eye of the storm, which, okay, there's someone may benefit from services, might not be the same as a 20 when someone's filling it in a week later and thinking about it. Understanding what this actually means from a clinical perspective is really important. As part of the next grant we're thinking about is trying to follow up with a subset of those that do score, to seeing how their scores actually translate to a SIPS. So understanding if these kind of psychotic-like experiences that they're putting in a self-report form online in the comfort of their home or whatever actually translates to something which is how we define as kind of clinically meaningful and something that we would progress in care afterwards. I think that's a huge part of that. So understanding what these numbers actually mean in the context of what care services someone may want or need. So I think that's a huge part of what we're thinking about. And again, another, I think, big next step that we're thinking about is just trying to traverse this gap, which I've mentioned a couple of times now, from the idea of filling in a screener to actually committing to treatment. I think is a huge step for anyone. And the numbers, I mean, just asking people, 17% of people want treatment. So the vast majority aren't there yet, or at least before they've spoken to someone else and kind of made that step. And that's data we see in other studies as well. Again, Michael Birnbaum and Strong 365, they had a lot of engagement in their website, but even with a lot of kind of peer support, counseling services, everything else, the jump to actually getting someone committed to treatment has been a challenge. So I think that's a huge part of what we're thinking about as well. Like, if this is actually going to be a pathway for people to take, then we need to kind of follow it to its endpoint for it actually to be useful. And there's one thing to find a ton of people. It's not that useful if that's just where the line stops. Okay, we know there's a ton of people that are in need and are suffering, but that doesn't actually change in terms of the suffering their experiences or the care that they have. Then, I mean, it's important to know, but it doesn't change the experience of the person that's having it. So I think that's another key part for us is, one, understanding what these numbers actually mean. Are people experiencing clinical high risk and psychosis in the numbers that we may expect based on previous studies? And then secondly, how we traverse this kind of chasm that's there to actually being able to meaningfully provide support to people that are suffering.
Well, that seems like a good place for us to wrap up. Thank you so much for joining us. I know you've got the full day in front of you there on the West Coast now. But we really appreciate it. It was a fascinating discussion. We're really looking forward to hearing all the questions that come from the questions.
Great.
Thank you.
Thank you so much for the opportunity. It's been fun. Thank you.
Very provocative and really generative paper. I'm so appreciative to Mark for coming on. So that's it for today. We invite you to visit our website, ps.psychiatryonline.org, to read the article we discussed in this episode, as well as other great research. We also welcome your feedback. Please email us at psjournal@psych.org. I'm Lisa Dixon.
I'm Josh Berezin.
See you next time.
Join the APA Foundation in crucial conversations around mental health where you live, learn, work, worship, and play by listening to our podcast, Mentally Healthy Nation. You can find archived as well as our latest episodes on decriminalizing mental illness and zero tolerance policies by visiting mentallyhealthynation.org. We hope to see you there.